Dr. Roshan, can I start?
Yes, madam, can start. Yes. Also, we are live streaming on the following link. So anybody cannot join can do the live streaming on the following. Please share with your group mates if they can't join. Thank you.
Okay. Can everyone see my screen and is it clear?
Yes, madam, can see. Yeah.
Roshan, can I start?
Yes, madam, can see.
Okay. Good morning, everybody. So within the next 20 to 30 minutes or so, we are going to talk about blood gas analysis and their basic interpretation. So the objectives, as I told you, I'm going to tell you how to perform a blood gas, especially arterial blood gas sampling, and the basic derangement, basic interpretation. Here, what I'm going to talk to you is about the metabolic panel as well as the gas exchange. So blood gas analysis or an interpretation is a very vast and a complex subject, but today I'm going to talk about only the simple blood gas analysis. So you all know blood gases measure how much oxygen and carbon dioxide is in our blood. And in addition to that, it also determines the acidity or the pH of our blood. So I'm sure in your medical student days, most of you, almost all of you have gas report, either an arterial blood gas or a venous blood gas report. So when do we do arterial or venous blood gases? So especially in ICU or HDU setups, patients who are on the ventilator, we usually do arterial blood gases. The patients who are on respiratory failure and being ventilated. That is because we want to know the extent of the gas exchange in the lungs, the level of oxygen and the level of carbon dioxide. And also, we do perform blood gases, maybe venous blood gases can give us useful information in conditions like any other organ failures like heart failure, liver failure, renal failure, diabetic ketoacidosis, and sepsis. And also, we perform blood gases, serial blood gases, to assess the response to our interventions. For instance, imagine there's a patient on ventilator for type 1 respiratory failure, and we have increased our FiO2, and in about 1 hour or so, we would like to know what change has been done in the patient's oxygenation level from our therapeutic intervention. So to assess the response to our therapeutic intervention, we perform serial blood gases. So those are the indications where we perform either arterial or venous blood gases. So the main difference in arterial and venous blood gases is, as you can appreciate, it's the level of oxygen and the level of carbon dioxide, the partial pressure of oxygen and the partial. So as you all know, partial pressure of carbon dioxide is much higher in an arterial blood gas compared to venous blood gas, and the partial pressure of carbon dioxide is about 5 millimeters of mercury. There's a in venous blood gases, the PCO2 or the carbon dioxide tension is about 5 millimeters of mercury higher than the arterial blood gas. Other than that, the metabolic panel wise, it's more or less the same. So what are the equipment that you need in order to perform an arterial blood gas? Obviously, you will need a blood gas analyzer, and also you will need a heparinized syringe. Ideally, we take 1 ml heparinized syringe. So what is the amount or what is the volume of heparin that you need to take? So the sole aim of using heparin in our syringe that we use to take blood gas is to prevent the blood sample clotting, because heparin is an anticoagulant. But we need to take the bare minimum volume of heparin that is required to coat the inner surface of the syringe. So once you have coated the inner surface of the syringe with heparin, And before you going to take the sample, you need to flush it. You need to discard the heparin, the residual heparin inside the syringe, because heparin is basic and it can interfere with our acid-base status on the blood gas report. So therefore, remember to take the bare is required to coat the inner surface of the syringe just to prevent the sample getting clotted. And before you take the blood sample, always flush the heparin out. Okay. So other than that, you will need your cleaning stuff, your alcohol wipes and gauze. And sometimes if the patient is very anxious, you can give some local anesthetic before you do the puncture, but we hardly give local anesthetic before we get a blood gas. And also your protective equipment, your gloves and your apron. So you have to introduce yourself. These are the basic things. You have to introduce yourself to the patient, confirm patient details, check whether this is the correct patient that you need to get a blood gas. And also, most importantly, you need to check whether there are any contraindications for arterial puncture, such as presence of arteriovenous fistula, peripheral vascular disease, patients with poor collateral supply where we can't do any arterial samplings, and also impaired coagulation, like very low platelet counts and also very high INR values, where you can't puncture an artery because it wouldn't stop bleeding if you puncture an artery at that point, if the patient's coagulation is already impaired. So in such an instance, as you are starting your career, please don't do any arterial blood gas samplings in those patients, but please seek senior advice on such patients. Right. So once you have excluded the contraindications and you are ready to good to go, you have to explain the procedure to the patient and take their consent. So the common sites where we do arterial blood gases or where we do arterial punctures include most commonly radial artery, brachial artery, femoral artery, and also we do blood gases in dorsalis pedis artery as well. So most commonly we perform blood gases in the radial artery, especially in the patient's non-dominant arm. So you have to take the patient's non-dominant arm and lie it preferably on a pillow for comfort. So the secret to success is you need to keep the patient's wrist extended to 30 degrees. And for that you can keep a roll under the wrist. So once you have positioned the patient's arm, you can palpate the patient's radial artery with your non-dominant hand's index finger about 1 centimeter proximal to the planned puncture site. And then you have to clean the area with alcohol. You have to you should have worn your gloves by now and the apron. So you need to clean the area, and then you have already prepared your heparinized syringe, and then you can insert the needle. But before you insert the needle, at the point where you feel the maximal pulsation, you need to warn the patient, look here, I'm going to insert this needle, you will feel this slight pain. Otherwise, the patient will move and you won't be successful. So you have to insert the ABG needle through the skin at an angle of 45 degrees over the point where you feel the maximal radial artery pulsation. And then advance the needle gently into the artery until you see a flashback of blood. So if you are in the correct place, you will see that the syringe will begin to fill itself, because it's an artery, automatically fill with the arterial pressure and the pulsation. So what is the required amount of blood that you need to take? So normally blood gas analyzers will require a volume of about 0.3 to 0.4 ml. So you have to take at least 0.5 ml of blood in order to take a good result. So I would recommend you to take at least 0.5 ml or somewhere between 0.5 to 1 ml is okay. But don't take less than 0.5 ml, because you might have to repeat the procedure if the sample is not enough. So at least 0.5 ml you need to take. So it should be like somewhere between 0.5 to 1 ml is good enough. So once you have collected your sample, you have to remove the needle from the artery, and then as soon as you remove, you have to apply immediate firm pressure on the puncture site for about 3 to 5 minutes, and then apply a tight dressing and thank the patient. Right. So once you have removed your sample, then in our setting, in our practically what we do is we pierce the needle into a rubber cap and place our sample in an ice bath if we don't have an on-site blood gas analyzer. If we do this in an ICU or where there's an on-site blood gas analyzer, you don't need to do this. You can simply take your sample quickly to the blood gas analyzer and get it read. But mostly in the both setups, what you have to do is you have to pierce a rubber cap with your needle and then place it in an ice bath and then label it properly and send for analysis. Make sure there are no air bubbles in the in which you have taken the sample. So what are the important things that you need to mention on your label? Obviously, you have to mention the patient details, name, age, and the BHT, and also the patient's body temperature and the fraction of inspired oxygen. If the patient is breathing normal room air, FiO2 is 21% or 0.21. Okay. Likewise, you have to mention the oxygen concentration the patient is on. So once you have sent your sample for analysis, you can dispose your gloves and equipment into your clinical waste bag, and of course, don't forget to wash your hands. Right. Ideally, we should analyze the blood gas sample as soon as possible. Should be done within less than 10 minutes time, because blood contains cells like red cells, white cells, platelets that consume the oxygen and glucose in the sample, so that your final result will be erroneous if it gets delayed. So if it gets delayed, what you have to do is to keep your sample in an ice bath at 4 degrees of centigrade. So taking a blood gas sample, the method I told you is a direct puncture. But there is another method, especially in ICU setups, where you don't have to do an arterial puncture because the patient already has an arterial line in situ. So you don't have to do a second on an artery to take an arterial blood sample. You simply have to use the patient's arterial line to take the blood sample. So I'm not going to talk about the sampling through an arterial blood gas, arterial line, because I think it's better you learn it practically when you encounter such a patient in an ICU. Always you need to observe when somebody experienced who is doing that and then learn it rather than me explaining it. Just remember that if you ever encounter a patient with an arterial blood gas in an ICU setup, you don't have to do a second arterial puncture on a different artery. You can take the sample from the existing arterial line. Right, moving to our main topic. So I told you that I'm going to talk about the simple blood gas analysis. Out of that, there are two categories. One is acid-base balance and the other is gas exchange. The gas exchange part is more important to us these days because of this COVID pandemic. So let's quickly look at the acid-base balance. So you all know that our body pH is maintained within narrow limits. The normal body pH is 7.35 to 7.45. If the pH is more than 7.45, you call it alkalosis or alkalemia, high blood pH. And if the pH is less than 7.35, you call it acidemia or acidosis. So these acid-base shifts are largely controlled by three main buffers in the body, namely proteins, hemoglobin, bicarbonate, carbonic acid bicarbonate system. So I'm sure most of you have seen a blood gas report during your clinicals. So these are the 5 key components that you need to look at when you interpret a blood gas report. Obviously, the first thing you have to look at is your pH, and then the oxygen tension, carbon dioxide tension, bicarbonate level, base excess, and the deficit. So, what information can you gather when you interpret these components of a blood gas report? So, pH, from your advanced level knowledge, you know pH is the negative logarithm of the hydrogen ion concentration in blood. So, in other words, higher the pH, lower the hydrogen ion concentration. And PO2 is the partial pressure of oxygen dissolved in arterial blood. Similarly, PCO2 is the partial pressure of carbon dioxide dissolved in arterial blood. SaO2 is the percentage of oxygen bound to hemoglobin, and bicarbonate gives you the concentration of bicarbonate in blood, which is regulated by the kidneys. So, what is base excess? So, the normal value for this parameter is positive 2 to minus 2. Why is it called base excess or base deficit is, to tell you simply, it is the amount of base that would have to be added or removed to a blood sample with an abnormal pH to restore to a normal pH. Amount of base that would have to be added or removed. That's why it's called base excess or deficit to a blood sample with an abnormal pH to restore to a normal pH. Right. So these are the desired range of values for these parameters mentioned in the blood gases. It's remember these parameters so that when you read a blood gas, you can detect the abnormalities easily. So pH, you know, the normal value is between 7.35 to 7.45. PCO2, the normal values is 35 to 45 millimeters of mercury. Oxygen level should be between 80 to 100 millimeters of mercury in an arterial blood gas report. Bicarbonate is 22 to 26 millimoles per liter. Saturation somewhere between 95 to 100. Base excess plus or minus 2 millimoles per liter. Lactate 0.8 to 1.5 millimoles per liter. And the normal ranges of the electrolytes like sodium, potassium, magnesium, calcium, and the blood glucose level. Moving to the stepwise approach to basic blood gas analysis, there are two main steps. The first step is to look at your pH. Now you already know the normal pH is 7.35 to 45. You call it alkalosis when it is above 7.45. You call it acidosis when it is below 7.35. Your second step in the blood gas analysis is to look at your carbon dioxide tension and the bicarbonate. So out of these two, one will denote the primary disorder and the other will denote the compensatory response. So how are we going to differentiate that? So this I have already mentioned. The first step, looking at your pH. If it is less than 7.35, it's acidosis. If it is more than 7.45, it's alkalosis. So remember, pH may be normal in the presence of mixed acid-base disorders, which I'm not going to talk here. But the other parameters of the blood gas will be abnormal despite the pH being normal. So in that case, you have to suspect this is a mixed acid-base disorder. So we'll talk about the simple ones first. Right, now you know from your pH, you know whether it's an acidosis or an alkalosis. Right, so then you have to look at your CO2 tension and the bicarbonate. So what is the acid-base process leading to abnormal pH? So in simple acid-base disorders, both CO2 tension and the bicarbonate level will be abnormal, and the direction of the abnormal change is the same for both parameters. So what it simply means, if your CO2 tension is high, your bicarbonate level should be also high. That is why it mentions the direction of the abnormal change is the same for both parameters. So as I go along, you will understand more. Don't worry if you didn't understand this statement. So out of these two, as I have already mentioned, one abnormal value will be the initial change and the other will be the compensatory response. So you have to distinguish the initial change from the compensatory response. So how do we do that? So the initial change will be the abnormal value that correlates with the abnormal pH. For example, from your pH, if it was more than 7.45, you know it's an alkalosis. So for an for you to say it's an alkalosis, you know that your CO2 tension should be lower than the normal, or your bicarbonate should be higher than the normal. In contrast, if the pH was if the pH showed acidosis, then you know your CO2 should be higher than the normal value and the bicarbonate should be lower than the normal value. That is how you are going to detect the initial change. So once you have identified your initial change, then obviously the other abnormal parameter is the compensatory response. If there's no, if you can't find any compensatory response, suspect a mixed disorder. So simply, you can identify your initial change, and when you look at the other parameter, that will be the compensatory response. I'll do some examples, then you will understand better. Don't worry if you didn't understand these things. So once you have identified the initial change and the compensatory response, you can identify the specific disorder. For example, if PCO2 was the initial chemical change, you call it a respiratory disorder. If the initial change was in carbon dioxide tension, you call it a respiratory disorder. Your primary disorder is respiratory. Similarly, if the initial chemical change was in bicarbonate, the process is a metabolic disorder, primary metabolic disorder. Right. Let's go through these one by one. So it says respiratory acidosis. So you know your pH is less than 7.35. Since they have mentioned it's respiratory acidosis, you know your primary change should be in the carbon dioxide tension. So initial change is raised PCO2. The compensatory response is increased bicarbonate. Similarly, respiratory alkalosis, your initial change is reduced carbon dioxide. That is why you call it a respiratory alkalosis, and the compensatory response will be reduced bicarbonate. Similarly, if your initial chemical change was reduced bicarbonate, you know it's a metabolic process, and the compensatory response will be reduced CO2 just to get rid of the acidosis from the body. If your initial change was rising bicarbonate, you know it's a metabolic process, and then the compensatory response will be raised PCO2. Right, let's go through some examples, then you will understand better. So, if a patient's respiratory rate is less, or if the patient hypoventilates due to effects of drugs like opioids or due to head injury or respiratory failure, if the respiratory rate is lower than the normal range, obviously the patient will accumulate carbon dioxide. So this carbon dioxide, you all know, gets hydrated into carbonic acid, which will dissociate into hydrogen ions and the bicarbonate. Bicarbonate ions will be lost through urine, but hydrogen ions will be in the body, causing an acidosis. So similarly, if the patient hyperventilates, if the respiratory rate is higher than the normal range, the carbon dioxide is washed off from the body. So there are certain situations like in young females, especially some anxiety disorders and emotional disturbances where they hyperventilate, washing off their carbon dioxide, which will cause a respiratory alkalosis. So let's look at this example. sorry, 21-year-old boy, sorry, so it says a 21-year-old woman presents feeling acutely lightheaded and short of breath. She has her final university exams next week. They have performed the blood gas. So from the steps that you learn, so look at the pH first. So from that you can say the pH is 7.48, which is an alkalosis because the pH is more than 7.45. Then you need to look at your PCO2 or the bicarbonate. So if it is an alkalosis in simple acid-base disorder, you know either your bicarbonate should be high or your CO2 should be lower than the normal range. So when you look at your CO2, I told you the normal CO2 tension is between 35 to 45. So you can gather CO2 is lower than the normal range and your bicarbonate is within the normal range, which was 22 to 26. So from that, your initial chemical change is, you know, it's a primary respiratory disorder. It's a primary respiratory alkalosis. And the bicarbonate is also going down. It's within the lower normal range. It's 22. So similarly, in metabolic acidosis, what are the examples for metabolic acidosis? So metabolic acidosis can happen due to accumulation of hydrogen ions or due to loss of bicarbonate from the body. Examples include lactic acidosis, where there is accumulation of tissue metabolites, and diabetic ketoacidosis, where there is accumulation of ketone bodies, and also renal failure. So this example, a normally fit and well 11-year-old boy presents with diarrhea and vomiting. He is complaining of non-specific abdominal pain. And this is a venous blood gas. So your 2 steps, remember your 2 steps. First step is to look at your pH. So pH is 7.12, is well below your normal 7.35 to 7.45. So you know this is an acidosis. So what is your second step is to look at your CO2 or the bicarbonate. So CO2 is 24, which is low, bicarbonate is low. So in an acidosis, the CO2 should be high and the bicarbonate should be low. So from that you can gather the bicarbonate is low, but the CO2 is also low. So your primary initial change is bicarbonate. So it tells you that this is a primary metabolic disorder. The compensatory response has been happened in your CO2 tension. So this is a primary metabolic acidosis with respiratory compensation. So similarly, when we talk about metabolic acidosis, what are the instances where there can be metabolic alkalosis is where there is loss of bicarbonate, poor fluid from the body, like in patients with vomiting, where they will lose hydrochloric acid from the body, so that there will be increased bicarbonate in the body. And also nasogastric suction, similar thing. Nasogastric suction leads to loss of hydrochloric acid from the body, and some diuretics can cause metabolic alkalosis as well. So look at this example. A 67-year-old man with a history of peptic ulcer disease presents with persistent vomiting. Now remember your steps. The first step is to look at your pH. Now the pH here is 7.56, which is well above your normal value 7.35 to 7.45. So you can gather that this is an alkalosis. If it is an alkalosis, either your bicarbonate should be high and your carbon dioxide should be low. So if you look at your bicarbonate, it's high, and the carbon dioxide is also high. So your primary initial chemical change is rising bicarbonate, which makes this a metabolic alkalosis with respiratory compensation. Right, that is mainly about the simple acid-base balance. Now we are moving on to the gas exchange, which is more important to you in these days because of this COVID situation. So we all know lungs are the organs that will do gas exchange, extracting oxygen and removing carbon dioxide from the blood. So when we talk about the gas exchange from an arterial blood gas report, these three are the most important things: your partial pressure of oxygen, partial pressure of carbon dioxide, and the PF ratio. I will tell about PF ratio in a minute. Right. In a patient who is breathing normal, in a patient who has normal lungs and breathing room air, the saturation will be more than 94%. And that patient will have a PO2 of about 8 to 100 millimeters of mercury. Similarly, the patient will have a PCO2 of 35 to 45 millimeters of mercury. So those are the normal values in a patient who has normal lungs breathing room air. So in critical care medicine, we talk about two types of respiratory failure: type 1 and type 2. Type 1 respiratory failure is an oxygenation failure. In that, there will be low oxygen tension, but the carbon dioxide tension will be normal or low. So it's mainly oxygenation failure. In contrast, type 2 respiratory failure is where there is both hypoxia and hypercarbia. The oxygen tension will be low, plus there will be accumulation of carbon dioxide as well. So when you say hypoxia, so if the arterial oxygen tension is less than 60 with normal or low PCO2, we call it a type 1 respiratory failure. So type 2 respiratory failure, on the other hand, is a ventilatory failure. So it has both hypoxia and hypercarbia. So there will be low PO2, less than 60 millimeters of mercury, plus there will be high CO2 as well, more than 45 millimeters of mercury. So those are the main two types of respiratory failure that is being described in critical care medicine. So let's look at this example. Right, you are called to see a 54-year-old lady on the ward. She is 3 days post cholecystectomy and has been complaining of shortness of breath. Her ABG is as follows. So this is, remember, this is, I have included this to show you, to differentiate the respiratory failure. So when you look at the PO2, remember I told you if the PO2 is less than 60, it's hypoxia. So her PO2 is 57. The CO2 is slightly less than the normal range, which is 35 to 45. So you can see that this is a type 1 respiratory failure, which is mainly oxygenation failure. Let's move on to the next example. A 64-year-old gentleman with a history of COPD presents with worsening SOB and increased sputum production, and this is his ABG. So you can see the PO2 is 55, which is less than the normal 60, and the CO2 is 65, which is more than the normal range of 35 to 45. So you can appreciate that there is both hypoxia and hypercarbia. So this is an example for type 2 respiratory failure. Right. So now we have talked about the partial pressure of oxygen and the partial pressure of carbon dioxide. So this is the third oxygenation index, which is the PF ratio. I'm sure most of you have heard of this index. It is the ratio between the partial pressure of oxygen and the FiO2, the fraction of inspired oxygen. So to make it more simple, let's take you or me. What is my normal PF ratio? So I am a person with normal healthy lungs. So my PO2 when I am breathing room air will be close to 100 millimeters of mercury. Let's say it's 100 millimeters of mercury. And what is the FiO2? At the moment I am breathing room air. So the fraction of inspired oxygen will be 21%, which is the normal atmospheric oxygen concentration. Oh, 0.21. When we say fraction, we normally say it 0.21. So my PF ratio at this minute will be 100 divided by 0.21, which comes to about a value of 476. So that is normal. So depending on this PF ratio, we classify the acute respiratory distress syndrome into 3 categories depending on the severity of this index. So now you can appreciate in a normal healthy adult, the PF ratio is above 400, somewhere between 400 to 500. But if it is less than that, that means either your oxygen FiO2 is high and the PO2 is low. It's simple mathematics. If the PO2 is lower and the FiO2 is higher, this ratio will be low. So depending on that, they have classified the acute respiratory distress syndrome into 3 categories. If the PF ratio is between 200 to 300, they have classified it as mild ARDS. If it is less than 100, you will appreciate it's a severe ARDS. The simple reason being the PO2 is lower and the FiO2 is higher. That is, the patient's oxygen requirement is going up and the oxygen tension is low. That is why the PF ratio is low. Right. So I have discussed about the simple acid-base disorders plus the gas exchange indices. So in summary, arterial blood gas is a bedside simple test which needs proper sampling and transport if you don't have an on-site blood gas analyzer. So we have discussed the basic acid-base interpretation and the blood gas criteria for type 1 and type 2 respiratory failure and the oxygenation indices. So these all are numbers. So what is very important is the clinical history. You can use these blood gases to help with your treatment modality. So make sure that you stick to the clinical history first. That comes to the conclusion of my presentation. Are there any questions?
Dr. Hashika?
Yeah.
There were some questions regarding my lecture, so I was like just inserting those. Sorry for that.
Right. I think there are a lot of.
Do we have time to go through these?
Yeah, there are lots of questions. I think if we're going to answer those, it will take a lot of time. So I think, madam, you can answer them on a chat box. So we can go to the next lecture. I think.
Okay.
Yes. So it's by Dr. Saman Nanakar. Over to you, sir.
Yeah. Okay then. Thank you.
Thank you, madam.
Can you see my screen? Can you see my screen? Hello? Hello?
Yes, I can. Not yet. Dr.
Okay, slide sharing.
Yes. Dr. Harshika, you have to stop sharing, I think.
Yes. You have to close your screen, Dr. Harshika. Can you see my screen? Can you see my screen?
Not yet, sir. Not yet.
Harshika, have you stopped sharing your screen? Can you see the screen now?
No, sir. Not yet, sir.
Okay.
Can you see it now?
So no. So so close all the whatever you have open.
Yeah. Yes.
And then go to share screen.
Yes.
Now try click. You have to click for done and click the sharing screen and then share it. Is it coming? No.
Can you see it now? Yeah. Can you see it now?
No. So are you using Apple?
Yes.
iPad.
Yeah. Yeah. Apple iPad.
In that case, okay. So press share, then go to advanced.
Share screen. Yeah. Yes. Oh. Portion of screen. Share. Can you see it now? Can you see it now, Roshan?
Sir, we can see the part of the screen, sir.
Okay, so then I will cancel it. Wait, I'll get it. Wait, Roshan, I'll get it. Sorry for that. Till then, I close my video. Close steps. We will close everything.
Now it's okay, sir.
All right, fine. Okay. Okay, so sorry for the delay. Now it's very good afternoon for everybody. So we'll be concentrating on acute pain management over the next 25 minutes. Right. So at the beginning, I must emphasize your role as an intern house officer when it comes to managing pain. So as far as pain management is concerned, and for that matter, when it comes to managing anything else, intern house officer is the team leader. So don't get away with the idea that consultant, senior registrar, senior house officer, everybody is there, sister, senior nurses, everybody is there. Then you are at the bottom of the hierarchy. You may be at the bottom of the hierarchy when it comes to administrative matters, but as far as patient management is concerned, intern house officer is the most important person in the ward or in that unit. So same thing applies to pain, and you have to understand that it's your input, your assessment, and your management what is important for patients when it comes to pain management. Can you hear me? Hello?
Yes, sir. Can hear.
Okay, so at the beginning I will...
Can hear, sir.
Okay, so I'm sharing the definition of pain. And as all of you know, pain is an unpleasant sensory and emotional experience associated with, or resembling that, associated with actual or potential tissue damage. So therefore, we are referring to a tissue damage whenever we are talking about pain. Right, so this is a diagram reminding you how pain is felt for people. Now at the bottom you can see there are free nerve endings which are the receptors for pain. So this is at the periphery, and this is called transduction. So the tissue damage will be felt as a nociception. And local anesthetics and anti-inflammatory drugs can work here. And then the pain messages would be going along in the dorsal route and entering the spinal cord from the dorsum aspect. And so local anesthetics again can block transmission. So this is the transmission stage. And in the spinal cord, you have central transmission. Earlier, you had peripheral transmission. So the nerve impulses that are carrying pain would cross to the opposite side of the spinal cord, now will ascend in the lateral spinothalamic tract. So this is the ascending tract that will ascend, climb to the thalamus. From the brain, there will be descending tracts coming to the spinal cord, and therefore these parts can be blocked with central transmission blockade by local anesthetics like in epidural or spinal, or using opioids or alpha-2 agonists like clonidine. Then this descending pathway that modulates pain. So now you have to remember, if not for the descending pathway, which is controlling pain, which is reducing pain, which is reducing the intensity of nociception and pain, we will experience a lot of pain, if not for the descending modulation. And brain is the final destination when it comes to interpreting pain. And well, brain and the mind. So mind is above the pain, mind is outside, mind is above the brain, mind is outside the brain, mind is all over the body, it's outside the body. Well, it is integrated with the body organs also. Final interpretation of whether this tissue damage is painful or not will be done by the mind together with the brain. Right, so I want to share another important diagram which you are very familiar with. WHO pain ladder. So you know this is a ladder, as you can see, climbing up or climbing down. So when you have a patient with severe pain, start from the top of the ladder. Start with the top of the ladder, give a dose of morphine together with paracetamol and an NSAID. Once the patient's pain is controlled, you can come down. Now you can probably stop giving morphine or pethidine, give only paracetamol and NSAIDs. Maybe you can add paracetamol to codeine and give as rapidine or panadine. When the pain is more controlled, you can step down further. Now paracetamol alone may be enough, or NSAID alone may be enough. Similarly, if you have a patient with chronic pain, you can start slow from the bottom and can go up. Right, so most of the large hospitals, teaching hospitals in this country now have pain teams. They have, so a pain team would consist of a pain specialist, senior registrars, MOs, pain nurses, and there'll be a contact number for that office. So it's very important that you develop a relationship with the pain team in the hospital that you are working. So from them, you can get advice, consultation for managing difficult patients. In the hospitals where there are no pain teams, organized pain teams, you can always liaise with the anesthesia consultant, or if there's an anesthesia postgraduate or registrar or senior registrar. So I must remind you, pain is the commonest symptom in the world. It's the commonest complaint, and it's the commonest reason to see a doctor, and it's the commonest reason to come to a hospital. However, pain is very commonly ignored by the medical profession. Doctors, nurses both forget pain. Pain has been the reason for the patient to come to the hospital. Now we start chasing the diagnosis, we are doing biopsies. It's good to do all that. And we are treating with antibiotics, everything. And finally, we may have forgotten even to prescribe an analgesic. So remember this slide very well. Pain is very commonly ignored, forgotten by doctors and nurses both. And pain reduces quality of life, it reduces activity, and will lead to multiple complications. So now, why should we treat pain? So we have to treat pain on humanitarian grounds. All health staff, all humans should attend to others' pain. Well, there are medical reasons also. If you do not control pain, there will be lots of medical complications that can happen to a patient, and they will further complicate the primary problem the patient is having. So we will see what those things are. Now, for instance, pain can affect the sympathetic nervous system, and there will be tachycardia, hypertension, and tachypnea related to pain. Pain will affect the cardiovascular system. So it can lead to angina, or a myocardial infarction, or arrhythmias, or it can worsen cardiac failure in a patient who is more prone for those things. I'm not saying that the patient will have an angina or myocardial infarction. If it is a 15-year-old in the prone age group, in the middle ages, elderly, they very well can have a myocardial infarction or acute coronary syndrome, arrhythmias, worsening of cardiac failure due to pain. Then pain will lead to exaggerated stress response to trauma, to surgery, and to illnesses. In addition, pain will have a separate stress response called stress response to pain. And researchers have found stress response to pain is more severe than stress response to surgery, illness, or trauma. Now you will see pain is a systemic disorder. The patient may be having pain in a single part of the body, but pain is a systemic disorder. And pain will reduce mobilization of a patient. It will lead to deep vein thrombosis, pulmonary embolism, pneumonia, pressure sores, muscle wasting, and it will affect the respiratory system and will lead to reducing depth of breathing, especially when the pain is in the chest or the abdomen. So it will reduce the depth of breathing. Finally, it will lead to atelectasis, may even for a lung collapse, hypoxia. Pain will reduce cough, reduce the expansion of the chest, finally leading to retention of secretions, and the patient will end up with a respiratory tract infection or maybe a pneumonia. It could be a fatal pneumonia. I said pain is a systemic disorder. It will affect the genitourinary tract and the gastrointestinal tract. So under genitourinary tract, you can see it can lead to urine retention. So sometimes you may be called in the middle of to the ward. Let's say a patient who has undergone minor surgery, maybe a herniatomy, and to see the reason is patient is having pain. And pain will affect the gastrointestinal system, where it will reduce motility of the gastrointestinal system. It will delay gastric emptying. It can lead to gastritis, gastric ulcers, duodenal ulcers, and can lead even to constipation. Well, it will affect the central nervous system also. Pain will lead to mental stress. Stress will further increase pain, and pain will increase stress. Stress will increase pain. So it will be a cycle like that, one increasing the other. Pain will lead to anxiety, fear, worry, restlessness, depression, loss of sleep, loss of appetite. Patient will not be cooperative with your treatment because he's in pain. He doesn't want to listen to you. He's not following your instructions because he's in severe pain. Just give an analgesic. He'll be fine. He will be very cooperative with you. So what other deleterious effects do we have due to pain? There can be salt and water retention. And later, if you do not control a simple pain, there's a very high chance that the patient can end up with a chronic pain. And all of us know chronic pain is a headache to all health staff, and it will be very difficult to control chronic pain. And patients will develop also post-traumatic stress disorder. So that stress will be pain. Right, so in summary, poor management of pain will lead to loss of work, reduced productivity, and the patient who is suffering in pain will be a burden to the family, to the workplace, to the society, to our healthcare system. Our healthcare costs will be more because this patient is not going to leave the hospital soon, or he will be coming to the hospital very frequently, and patient will stay at home without going to work, so less productivity. Now, while trying to treat pain, you should spend at least 20 to 30 seconds to assess pain. So you can assess pain easily. There are many different ways, subjective ways, objective ways. Subjective ways is just asking at least a subjective question. Do you have pain? If so, how much? Mild pain, moderate pain, severe pain. So this we call verbal rating scale. It takes only 10 seconds for you to ask that. What I'm saying is you can't say you didn't have time to ask that. You can spend 10 seconds. You can measure pain objectively also, using different pain scales. One of the scales that you can use easily is a tool called NRS, numerical rating scale. You tell the patient, you can do it with an educated patient. If you don't have pain, your pain score is 0 out of 10. If you have the maximum pain under sun, it will be 10 out of 10. So where is your pain standing? 0, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Let's say the patient says my pain is 9 out of 10. So you give a dose of morphine, 0.15 milligrams per kilogram body weight, put a diclofenac rectal suppository, 1 to 2 milligrams per kg, give 2 tablets of paracetamol, 15 milligrams per kg, and assess the pain after 5, 6, let's say 20 minutes. Now the patient will say my pain score is 2 out of 10. So you have measured pain objectively. Earlier it was 9 out of 10. Now it is 2 out of 10. So there are different scales. I'm not going to go into details. So why should we treat pain? Again, patient has come to the hospital with a primary injury. It may be a head injury, chest injury, or medical disease like pneumonia or myocardial infarction or burn. And now the patient is going to have secondary injuries. Well, the primary injury has happened. You can't prevent it. You can treat the primary injury. You have to prevent secondary injuries. So what are the secondary injuries? There are many secondary injuries that can happen to a patient in the hospital. Hypoxia, hypercarbia, hypotension, infection, and pain is another secondary injury. So try to control pain. You can control pain. Therefore, by now you should understand that pain is a priority in the management of a patient. So you should not wait for others to control pain. Don't wait for the consultant to come. Don't wait for the senior registrar, SHO, senior nurse, or anybody to come. Don't wait for the person, doctor of the next shift to come. Don't wait till the following day morning. Don't wait till tomorrow to control pain. Control pain now. If it is 10 o'clock in the night, control pain now. If it is 12 o'clock in the night, control pain now. If it is 4 o'clock in the evening, you are about to go to quarters, use some analgesics now. The patient will benefit and your unit will benefit. Pain is a priority in the management of a patient. So in what stage of patient management should you control pain? Simple answer would be at all stages of management of a patient, you should control pain. So from this time of you dispatching a patient from, let's say the ambulance crew has gone to bring a patient. So in the developed world, the ambulance crew who goes there can control pain from there. So they might give a ketamine or morphine injection. We still do not have that facility in this country. Probably we can go to that stage someday. During the transferring of the patient to the hospital, if you are transferring one patient from one hospital to another hospital, keep them on analgesics. In the emergency department, OPD, during transfers within the hospital, in the pre-operative stage, post-operative stage, in the intensive care unit, high dependency unit, in the CCU, medical ward, pediatric clinic, gynae clinic, obs clinic, postnatal ward, antenatal ward, anywhere you encounter pain, control pain. So you should understand pain is a vital sign. Airway, breathing, circulation, disability. Fifth vital sign would be pain. Or you can consider pain under D. Right. So why do we not treat pain very commonly? So health staff forget to treat pain, or there are many reasons for not controlling pain properly. One reason is underassessment of pain. So if you haven't assessed, you can't, you don't know how bad is pain. So most of the times the staff might think the patient has no pain. The patient is not in pain. Primarily because the patient is not shouting. If somebody is shouting, crying, yelling, then you will see, okay, this patient has pain. But remember, if you are a patient and if you are in the ward, if you are in pain, will you shout? Will you cry? No. A patient who is a teacher, who is a principal, who is a postmaster, who is a businessman is not going to cry. He's not going to shout unless you go and ask either you or a nurse or somebody has to go and check whether they have pain. And another reason would be the staff is distracted by other injuries, other instabilities. Patient is bleeding, low blood pressure, breathing is affected, low saturation, then you are distracted by those things. So it's good to give priority to those things, but after sorting out those things, please control pain. Opiophobia. So we have learned about opioids, but we are the most scared about using opioids. So every time you have to use an opioid, most of the health staff are concerned whether this patient will have hypotension, respiratory depression. Those are very, very, those are not side effects that are going to happen all the time. If you use on the correct patient at correct time, those things are not going to happen. So what are the reasons that we are going to withhold analgesics? Fear of respiratory depression, fear of cardiovascular complications, fear of masking neurological signs, fear of addiction. So addiction is not at all a problem when you are using analgesics to control acute pain. Patients would not get addicted to morphine or pethidine just because you have used once, twice, thrice, 4 or 5 times of an opioid. Sometimes staff is not concerned about pain. Oh, they have no knowledge about complications of pain. Now we went through a big list of complications of pain. Sometimes staff does not have a knowledge about the possibility of patients having that kind of complications due to pain. Or finally, the patient, everything the staff has understood, but they do not know how to control pain. Right. So now let's learn how to control pain in the hospital setting, in the Sri Lankan setting. Very easy. Multimodal and multidisciplinary approach. We are talking about multimodal. Now we looked at the diagram of the pain pathway at the beginning. So we saw there are many different stages: transduction, peripheral transmission, central transmission, then reaching the thalamus, brain, and then finally the mind has to interpret this as pain. So it is, pain is finally a thought. So we have to use different drugs, different methods, different modalities to control pain at these different stages. That is why we call multimodal pain management approach. So as I mentioned earlier, you can use a dose of morphine, 0.15 milligrams per kilogram, stat, paracetamol, 15 milligrams per kilogram body weight, diclofenac sodium. Hello, can you hear me now?
So can you, sir?
Sorry, there was a disturbance. Right, so multidisciplinary means consultant, surgeon, VOG, nurse, attendant, everybody has to get involved in pain management. Right, so pain management is very easy. We are talking about an approach called RAT, R-A-T, RAT. So this is something put forward by World Pain Authorities to control pain. So there are only 3 things you have to do. R-A-T. R stands for recognizing pain. You have to recognize that there's pain. So you have to remember that all procedures are painful. It is maybe an IND, CND, dressing changes, maybe a mild trauma, appendicitis, appendicectomy, twisted ovarian cyst, draining the cyst. Everything is painful. So recognize there's pain. A stands for assessing pain. Assess pain. You need only 10 seconds. Ask the patient, hello, do you have pain? If so, how much? Mild pain, moderate pain, severe pain? How much out of 10? Thirdly, treat pain. So R-A-T, RAT approach. Remember, recognize that there's pain, assess pain, treat pain. How do you treat? The 2 things I mentioned at the bottom, pharmacological management and non-pharmacological management. Very easy. Right. Now, when it comes to treating, you have to look at the cause and try to fix the cause. If you are not addressing the cause, well, for an example, if the patient has an appendicitis, if you are not treating the appendicitis by an appendicectomy, then it will be very difficult to control pain. And in fact, you are doing worsening the situation. You might give morphine or pethidine and keep the pain hidden. Patient might finally have a rupture of the appendix, or might, if the patient has a bowel obstruction, finally there will be bowel gangrene and rupture, peritonitis, patient will die of multi-organ failure. When you have controlled pain with morphine and pethidine and kept the patient quiet. So try to find the cause, treat the cause, then use pharmacological and non-pharmacological methods. So for instance, examples for finding a cause are, if there's an abscess, drain the abscess, give antibiotics. If there's a wound, do cleaning and dressing, give antibiotics. If there's an acute appendicitis, do appendicectomy. If there are an ovarian cyst, twisted or bleeding, attend to that, do a laparoscopic surgery, drain it. If there's a bowel obstruction, take the patient for a laparotomy. If there's a fracture, do manipulation and anesthesia or open reduction. So those are examples for fixing the cause. Dislocation of a joint, reduce the joint. So this will be the summary of the rest of my lecture. I'm not going to go into all the slides. There's no time. This half an hour is enough for us to look at the entire picture of multimodal management. So looking for a cause, and then you try to control pain with pharmacological strategies, non-pharmacological strategies. Pharmacological strategies are using analgesics, drugs. You have simple analgesics like paracetamol and non-steroidal anti-inflammatory drugs. You have diclofenac, ibuprofen, many other things. You can use mild opioids like tramadol and codeine. You can use strong opioids like morphine and pethidine. You can use local anesthetic agents, lignocaine or bupivacaine. You can infiltrate the wound with bupivacaine, or you can do a nerve block by talking to an anesthesia registrar, or you can get the anesthetists to do an epidural. So regional anesthesia, example is epidural or spinal analgesia. You can use Entonox. Entonox has 50% oxygen and 50% nitrous oxide. There are many other adjuvant drugs like gabapentin and pregabalin, which are generally used for chronic pain. So we are not going to talk about chronic pain in this lecture. Then what non-pharmacological strategies do we have? So as I mentioned earlier, finally pain is felt in the brain, and in fact above the brain, in the mind. So you have to talk to the brain mind of the patient. Just talk to the patient, say, don't worry, you have this problem, we are attending to that, we are giving strong antibiotics, we are giving you saline, we will give you oxygen, we will give painkillers, your pain will be controlled, your illness will be controlled. And so give confidence to the patient. So that talking, explanation, counseling, all that will be very useful for controlling pain, and for that matter, controlling any other medical illness. And there are many other things under this topic that can be done to control pain. Those things generally are done for chronic pain, like cognitive approach, relaxation, meditation, and things like that. Transcutaneous electrical nerve stimulation is also something like that, which we use for chronic pain. Acupuncture, hypnosis can be used for chronic pain. Then for acute pain, another thing that you can do is maybe splinting, immobilization, or mobilization, physiotherapy, massaging, rubbing, elevation. Let's say your patient has undergone a surgery in the leg, so you keep the patient's leg elevated on 2 pillows. Or if he has undergone a surgery in the forearm, keep the patient on a collar and cuff. So some kind of elevation. So when it comes to principles of managing acute pain could be mild, moderate, or severe or excruciating. Consider the injury, comorbidities, patient's age, the type of injury, etc. Assess the severity of pain quickly. Believe what the patient says. So don't say, oh, no, there can't be this much of pain with this minor surgery or something like that. If it is painful to the patient, that is what you have to believe. In fact, another definition of pain is what the patient says hurting is pain. And ignore less important things like addiction and all. Those are things that you should not consider in the acute setting. Without any hesitation, you use opioids once or twice, thrice, 4 times, for the 5th time even if the patient is in severe pain. And use multimodal approach. Use adequate doses of correct drugs, reduce drugs later. So it could, for the same surgery, different patients can have mild pain, moderate pain, or severe pain. That is because the world is different, society is different, pain perception is different. Don't compare 2 patients. That patient didn't have that much of pain with this surgery. How can this patient have this much of pain? So the patients are different. So there are many types of barriers for pain management. So patient barriers, professional barriers, organizational barriers. We are not going to go into great details. And I'll give an example here and get ready teaching the lecture. So let's say you have a patient with a patient who has undergone a surgery or a patient who is after trauma. He's in severe pain. So assume all surgeries, all procedures are painful. Give them a good dose of opioids if they are in severe pain. Morphine is the better drug than pethidine. Use 0.1 to 0.2 milligrams per kilogram. 0.15 would be a good average dose. If the patient is 50 kilograms, give 7.5 milligrams. If the patient is 75 kilos, give 10 milligrams. So don't give low doses of morphine. I have seen lots of doctors writing very low dose of morphine. 3 milligrams of morphine or 4 milligrams of morphine, underdosing and later blaming morphine. So don't do that. Give the correct dose. Keep the patient happy. 0.15 milligrams per kilogram body weight. It will act for a longer time, 4 to 6 hours. Pethidine is a slightly less potent drug. So try to go for morphine. And there are concerns. Morphine might cause bronchospasm in asthma patients. But in the post-operative setting, still you can use morphine in a post-operative setting. An anesthetist might not use morphine during an anesthesia because we don't want intraoperative wheezing. In the post-operative setting, still you can use, well, if you are not using morphine, use at least pethidine. Slightly less potent, shorter duration of action than morphine, 2 to 4 hours. So action of pethidine could finish in 2 hours. That is something you have to remember. Dose is 1 milligram per kilogram body weight. Use paracetamol, 15 milligrams per kilogram body weight, 6 hourly or at least 8 hourly. In our hospital setting, drugs are given thrice a day. So use 15 milligrams per kilogram 3 times a day. For infants, 10 milligrams per kilogram is the dose. For less than 1 year, 10 milligrams per kilogram body weight. Use paracetamol, which is combined with codeine, like rapidine and panadine. Then you can go for NSAIDs. So we have non-selective NSAIDs like diclofenac sodium, 1 milligram per kilogram body weight, 3 times a day, not 2 times a day, 3 times a day with meals. Ibuprofen can be used 5 milligrams per kilogram body weight, maybe twice a day. Then if you are concerned about the patient's renal impairment or whether the patient will have bleeding or bronchospasm, then you can go for COX-2 selective ones like celecoxib. Now celecoxib is available in the hospital. For an adult, you can give 100 to 200 milligrams twice a day. Etoricoxib is also available. For an adult, you can give etoricoxib 60 milligrams, 6 milligrams per kilogram body weight twice a day. For a fairly built patient, for a small made person, you can give 60 milligrams once daily. For a bigger built patient, you can give etorecoxib 90 milligrams per day. You can also use tramadol, which is a mild opioid, but don't use tramadol and morphine together. Morphine is the more potent drug. Tramadol is a partial agonist. So if you use the full agonist and the partial agonist together, partial agonist can
Sir, your mic is muted, sir.
Sorry. Okay, fine. So don't use morphine and tramadol together. Use morphine on the first 1 or 2 days, then go for tramadol. And don't try to use diclofenac sodium rectal suppositories all the time. It is not pleasant to poke into the patient's rectum all the time. You can use diclofenac sodium orally. So instead of writing 50 milligrams suppository when necessary, write it 50 milligrams 3 times a day. So I have commonly seen doctors writing paracetamol 2 tablets SOS. So SOS means use it when necessary once only. PRN means use it when necessary, you can repeat many times. So theoretically it should be paracetamol 2 tablets PRN. So it can be used when necessary any number of times. If you write SOS, it can be used once only. My request is not to write it SOS or PRN, both. Don't write it. So if you write SOS or PRN, a nurse or somebody has to go and ask the patient whether they are pain. Now in our setup, not many people go to the patient and ask whether there is pain. So better to write it on a regular basis. As you clerk the patient, write paracetamol 2 tablets 3 times a day. Then that's finished. And don't try to wait to write analgesics. Prescribe analgesics at the end of your primary assessment. As you clerk patients, write analgesics. Then that's fine. And it's a good practice to put the patients on paracetamol 2 tablets even before surgery. So by the time the patient undergoes the surgery, there's paracetamol in the blood. And using local anesthetics is another very good thing, because when you use local anesthetic agents, you stop the pain messages entering the central nervous system. So if you use it for infiltration at the place of surgical incision or where the wound is, or if you give an epidural or spinal, you are stopping pain-related impulses entering the central nervous system. Therefore, the patient has no chance to have pain. So try and use those methods. Don't be bothered about lot of complications. If a patient is in severe pain, crying in pain, tachycardic, hypertensive, tachypneic, sweaty, then that patient will not get respiratory depression or hypotension due to an opioid. Use it without any fear. Use it without any fear. If the patient is fast asleep, no pain. Now if you go and give a pethidine or morphine dose, that is the patient who can have respiratory depression or hypotension or deep sedation. So you have to titrate the side effects also. If you think this patient has a higher chance of going into renal failure, don't use NSAIDs. Or if it is an elderly, don't use NSAIDs. So maybe on a borderline patient, you may use COX-2 selective NSAIDs for 2-3 doses and then stop. Then the pain will be less by that time. By the time you reach 36 hours, then you may continue with Panadine or Rapidine. So if you are using Panadine or Rapidine, give them a laxative also, because codeine is going to cause constipation. So put them on lactulose 5 to 10 milliliters, not 10. And when the pain is more controlled, you can stop Panadine or Rapidine, go only for paracetamol. So Rapidine is available now in the hospital setting. So now rest of the lecture is going to be on different groups of drugs, which I'm not going to do. I have finished my 30 minutes, so I'll stop there. If you have questions, if you post them on the chat box, I can answer those. Thank you very much, the critical care faculty, for letting me do this lecture. So before forgetting, remember, pain is very common. Pay enough attention to controlling pain and assess pain quickly. You need only 10 seconds. Use multimodal analgesia. Give morphine. Morphine is better than pethidine. Use an NSAID when you have a chance. If you think non-selective NSAIDs are not suitable for this patient, see whether you can use COX-2 selective ones. If you think COX-2 selective ones are also not good for this patient, don't use it. Use paracetamol together with codeine, Rapidine or Panadine. And if that is also not necessary, go for paracetamol. So try to use a combination of drugs and use non-pharmacological things like at least talking to the patient. Simple things like elevation, using methyl salicylate balm. Hospital has methyl salicylate balms or diclofenac sodium gel. Massaging, rubbing, elevation are things that can be used. Immobilization, splinting are non-pharmacological things that you can be doing. I'll be stopping there. Thank you very much. Have a good day. Roshan, I'm stopping there.
Yes, sir. I think Dr. Dushanti Atapattu is there. She can on management of massive hemorrhage. Until she starts, you can ask the few questions.
Okay.
So what's the indication between the diclofenac potassium and sodium? Different, I mean.
Yeah, so basically the two are the same, and some claim that diclofenac potassium has a better analgesic effect, but whether it has been proven scientifically, I do not know. Some people believe, but only things, diclofenac potassium is not available freely in the government hospital setup. So I try to concentrate on drugs that interns will be using in the hospital setup. But diclofenac potassium is good. So you don't use sodium and potassium both together.
Right.
So
Next
somebody has asked the dose of diclofenac suppository, 1 to 2 milligrams per kilogram body weight, and then towards the end of the action of the rectal suppository, you can start using oral diclofenac. So after most of the surgeries, patients can take oral tablets. So they don't have to wait for 6-7 hours fasting. They are awake by the time they come to the ward. So unless the patient has undergone a bowel surgery, all patients can have oral analgesics. Please go for oral analgesics. They can drink. Don't worry.
A few questions on morphine, sir. So, is the HO can prescribe? One question is, can the house officer can prescribe morphine?
They
And
they are the people who should prescribe morphine. Don't be scared. House officer is the most important person in the ward. You may have a professor working above you, consultant, senior registrar, but as far as the patient's pain management is concerned, they are less important people. Most important person is the house officer. Don't be scared. Use morphine. You can use morphine. You are authorized to use morphine. Choose the correct dose. For an elderly, go to the other side of the range, 0.1 milligram per kg. For a young, otherwise healthy, fit man, let's say a Rugrite has come, a fit farmer has come, use 0.2 milligrams per kg. A middle range would be 0.15 milligrams per kg. Subcutaneous. Don't use IV in the ward. Subcutaneous is better than IM. Just raise the skin, put the needle under the skin, that is subcutaneous. Pethidine IM route is better if you are not going to use morphine, use pethidine. 1 milligram per kilogram body weight is the dose. Don't underdose the patients. I think my time is up.
Okay,
Yeah?
the last question is, can people with heart failure can use morphine and something like yes?
Yes, yes. Morphine is a drug used for heart failure. In fact, if
Right.
you come across a patient with acute pulmonary edema, acute LVF, we use IV morphine 2.5 milligrams. So morphine is the drug of choice for morphine, heart failure. You can.
Okay, so I think that's all the questions. There are more questions. We can go to the next stage. Thank you very much, sir. Right. Thank you. Dr. Dushani Atapat, are you there?
Yes.
Yes, okay.
Okay. Okay, can close that.
Escape right now. Escape right now. Escape.
Okay, can y'all see me now? And can y'all see the
We'll make it full screen instead of. Right.
right? Can y'all see me now?
Can't see.
Can see the percentage. You can start.
Yeah, can see, no? Right. Shall I start?
Yes, madam. Can start.
Okay, right. Good afternoon. My lecture today is on it's not going. Right. Sorry about that. You all can see the screen, right?
Yes, can see.
Right, okay, I'll start. So my topic today is management of massive hemorrhage. So it is a very important lecture. It's not. What's it? Sorry, give me a second. Okay, so if you classify the for us to for our convenient, we'll classify the source the way of there are different ways of bleeding. So if it is based on the source of bleeding, it could be arterial, venous, capillary. So the arterial means that the blood would be bright red in color and it will be spurting along with the pulse. And venous, it's more dark red in color and steady and a continuous flow, whereas capillary bleeding is rapid and often torrential due to copious amount of oozing of blood, right? So but you know, when it is come to a trauma or other PPH or APH, whatever, the massive hemorrhage, you won't be able to see whether it's arterial or a venous or whatever. It will be just the pool of blood, right? So and if it is based on the time of onset of bleeding, it could be primary hemorrhage where it occurs immediately due to injury or a trauma, or whereas reactionary hemorrhage is usually it's delayed hemorrhage, which occurs within few hours and is usually due to dislodgement of the clot by your resuscitation maneuvers, and with that the normalization of blood pressure. And secondary hemorrhage is usually it's due to sloughing of the vessel wall. The wall of the vessel usually occurs within it's delayed type of bleeding, right? So that is usually 1 to 2 weeks after the injury, and it is precipitated with other factors like infection, pressure, necrosis, or malignancy. And if you classify the hemorrhage based on the type of hemorrhage, it could be revealed hemorrhage, which is very obvious external hemorrhage, and sometimes it's just concealed hemorrhage where it contains within the body cavity. So that there you have to anticipate or the suspect whether the patient is bleeding, because it's not quite obvious, you know, when especially during trauma, this is more common, the concealed hemorrhage, and it's very important for you all to anticipate and identify these patients quickly. So like examples in liver injury, spleen injury, fracture femur, ruptured ectopic pregnancy, cerebral hemorrhage. So these are the type of more concealed hemorrhage. And there are some sort of bleeding where it is initially concealed, but later it will be revealed, like hematuria, hematemesis, and melena. And then based on the duration of the hemorrhage, it could be acute hemorrhage where sudden severe hemorrhage due to, as I said, the trauma or even a surgery. And chronic hemorrhage, it's chronic repeated bleeding for a longer period, like in hemorrhoids and bleeding peptic ulcers. And sometimes it will be bleed after, you know, possible following some possible interventions like surgical hemorrhage due to direct injury, and then this non-surgical hemorrhage where general ooze from all surfaces, raw surfaces, and it's more due to the clotting anomalies, and the patient will go into DIC, and sometimes these bleeders cannot be controlled with the surgical means. So just before going into pathophysiology, I just want, you saw that there are many ways of classifying this hemorrhage, and I'm 100% sure during your internship you will definitely come across whatever the appointment you do, you know, medicine, it could be medicine, it be surgery, genonobs. This is a very common presentation, common scenario. So it's you are definitely going to get manage these patients. So it's very important to know to identify and to control and to how to manage them before they go into a irreversible stage, right? So if you talk about the pathophysiology, so the patients start bleeding, so that will lead to hypovolemia. So later they will have low cardiac output. So as a compensatory mechanism, you know, the body is trying to compensate by making the patient tachycardic, and it will shunt the blood from the splanchnic circulation by vasoconstriction. So that is to maintain the vital organ perfusion. So you know the vital organs, the brain, heart, and the kidney. There'll be more, whatever the blood is remaining, the body is trying to push the blood into those vital organs by vasoconstricting other splanchnic circulation. So then later, when it is go on like this, ultimately patient will go into tissue hypoxia, and when the anaerobic metabolism is take place, then there'll be electrolyte imbalances and metabolic acidosis, and in other hand there'll be activation of the platelets and coagulants, so ultimately causing disseminated intravascular coagulation with further bleeding. So it's a vicious cycle, and then the progressive hemodilution, which will lead to total circulatory collapse and multi-organ dysfunction causing death. So you have to identify these patients at the beginning, and your aim is to avoid going into that irreversible stage, right? So if you talk about the lethal triad of trauma, death, so these three important factors: coagulopathy, metabolic acidosis, hypothermia. So you have to take measures somehow to prevent these things occur, because if even one thing will be there, hypothermic, if the patient is hypothermic, if the patient's going into this hypoxia and causing metabolic acidosis, so then it's very difficult to reverse it back. So now you can understand why it is so important to catch these patients at the beginning. So now even though we said, okay, so how will you identify these patients? So when you talk about this hemorrhagic shock, there's advanced trauma life support. There is a classification where you classified into class 1, 2, 3, 4. That is mild, moderate, severe, and dying. So mild is where the patient lose the blood, the total volume of 15%. So that is less than 750 mils. And moderate, where 15 to 30% of blood has lost, so that is 750 to 1,500 mL. And in a severe, where 30 to 40% of your total blood has lost, so that is 1,500 to 2 liters has lost by this time. And in a dying patient, almost half of the blood has lost, so that is more than 40%, so that is 2 liters. So how will you clinically identify these patients? So that is, so you have your class 1, 2, 3, 4, and in other column, you can see that the clinical parameters. So you go by your system, your cardiovascular system, the respiratory system, and the kidney, the CNS. So all these are important. So look for so now you can see the class 1, where 15% of blood loss. So almost all the parameters are normal. So the patient would be conscious. So, so 500 to 750, they won't show any big deterioration in their clinical picture. But look, the class 2, still the blood pressure would be normal, right? There, the patient now has nearly 30% of blood is losing. But the patient start tachycardic, right? More than 100 per minute, and their capillary filling is prolonged by this time, and their tachypneic, so the 20 to 30 per minute, and the urine output is slowly coming down. And the patient, by this time, they are now a bit of hypoxic, so they'll be anxious. And then by class 3, the pulse rate is, the patients are severely, I mean, it's severe tachycardia, more than 120, and the blood pressure is low now with the more prolonged capillary refilling. And then the respiratory patient is severely tachypneic, more than 40, and then urine output is 5 to 20, and the patients are more confused. Right, in class 4, almost the patient's pulse rate is more than 140. The blood pressure, most of the time it's unrecordable because the blood, now the volume, most of the, I mean, about 40% is lost. And the prolonged capillary refilling will, you won't be feel any peripheral pulse, and of course the capillary refilling will be absent. And the respiratory rate, the patient would be severely tachypneic. I mean, by this time he may have, most of them, they may go into a respiratory rest. And the urine output is low, further low, and the patient is comatose by now. And so this is just a rough estimation of how to assess the blood loss. So you can see the soiled sanitary towels, it's about 30 mils, and a saturated small swab, so 10 by 10 one. So it's, that is the fully soaked one where the blood is now dripping. So it's fully soaked, right? And then the saturated sanitary towel, it's about 100 mils, and you can see the full kidney dish, it's about 500. So right, so if you measure, so these are just rough guidelines and the rough estimation, but the accurate way to measure the blood loss is to weigh the towels or the swabs. So you can, I mean, when you are managing these patients, it's going to be a teamwork. So don't worry, you can allocate a separate person, a nurse or a minor staff person to weigh these swabs, right? And so if you take a clot size of a clenched fist, it's about 500, and it's a closed tibial fracture. So again, these long bone fractures, they bleed massively inside. You can't see sometimes, so you have to suspect. So it is 500 to 1,500, and if it is a femur fracture, 750 to 2 liters. And so, as I said, weighing the swabs before and after use is an important measure to assess the blood loss. So hemoglobin, it is not a good indicator, but we go by this hemoglobin still. And so the management should based on the degree of hypovolemic shock according to your clinical parameters, and the preload assessment based deficit, and the fluid response to the fluid therapy. And then, so you can identify the patients who are responding and non-responding, or the transient responders. So bleeding, so you have to, yes, so the important thing is to identify the bleeding and stop it. And there's no point of keep on going, resuscitating with the fluid and the blood without controlling and stop bleeding. Right. So when it comes to the real management, hemorrhage must be recognized and managed aggressively to reduce the severity and duration of shock and to avoid death due to multi-organ failure. And as I said, the hemorrhage is treated by arresting the bleeding, not by fluid resuscitation or blood transfusion. But saying that the fluid resuscitation is necessary, it's very important as a supportive measure to manage, to avoid patient going into multi-organ failure, to maintain the organ perfusion. So to until you stop, identify and stop the bleeding, until such time, to by time you can have this fluid and the blood resuscitation. So attempting to resuscitate patients who have ongoing hemorrhage will lead to physiological exhaustion and subsequent death. So Yeah, so what are the principles of management? So as I said, identify the hemorrhage and immediate resuscitative maneuvers, control the hemorrhage and damage control resuscitation. And so how to identify external hemorrhage? So if it is an obvious external hemorrhage, you can put a swab or a towel or whatever and keep a continuous pressure until the bleeding is stopped. And when it comes to, you know, the internal hemorrhage, hemoperitonea following a trauma, it's not easy. You have to anticipate, you have to suspect. So the patient is bleeding, so you have your bedside other investigation like past scan. So these will be just will assist you to come to a diagnosis, but don't waste time until these sophisticated investigations come. So you have to manage in a hypovolemic shock, a trauma or whatever, PPH, APH, that sort of a patient with ruptured ectopic, if you suspect ruptured ectopic, so the patient is in a hypovolemic shock. So assume hemorrhage until proven otherwise. So what are your immediate resuscitative maneuvers? Your ABC, your airway breathing circulation, and call for help and inform your seniors. So even though you are the most junior person in the ward, you are the most important person when it comes to patient management in the beginning. So I mean, when it is you, most of the time, the HO is the first contact with the patient, right? In the middle of a night, patient comes with home delivery. I mean, these are not uncommon, right? Or a variceal bleeding. So the admitting officer just write, okay, HO to see stat. So it is you who is in the ward, is the first contact with the patient. So you don't forget your basics, ABC, and call help, because it's going to, if you anticipate a massive bleeding and massive blood transfusion, you can't manage it alone. So you have to call help and inform your seniors. So keep, as I said, if it is obvious bleeding, you keep direct pressure over the site of the external hemorrhage and elevate the lower limbs of the patient. So thereby you facilitate venous drainage thereby to increase more cardiac output and to have a good blood pressure. So, and give oxygen. So just give, I mean, take up oxygen, Hudson mask, keep on the face, increase to 8 to 10 liters per minute, give oxygen, right? So you are trying to avoid patient going into that lethal triad and further deteriorating of the condition. So, and then airway breathing should be assessed and controlled as needed. And so cannulation, the circulation. So you know this from your medical school stuff. So insert 2 big cannulas to 2 big veins. So that is 14 or 16 gauge cannula. So do it initially, because otherwise when the patient keep on bleeding, you won't be able to find good veins, because the veins are collapsed by that time. So if you can't find any veins in the upper limbs or in the lower limbs, go for the external jugular neck. So when you insert the cannula, try to go for a bigger cannulas, you know, at least okay, white is fine, but gray or orange cannula would be the best to manage these patients. So don't try to do the CVP and other things, not at all important at this moment. So anyway, not at your level, but but this wide bow cannula, these save lives, right? So important. So keep these things in your mind. And when you're cannulating, take blood for basic investigation, your full blood count, the serum electrolytes, serum creatinine, and the clotting profile, PTI, NRA, PTT, and the fibrinogen levels, and the grouping and the DT, right? And then so the blood is not available within minutes. So until blood is available, you have to give infused crystalloids rapidly. So that is 20 to 30 mils per kg. So give it within minutes, 10 minutes, 15 minutes, give fluids. Crystalloid is the fluid of choice in resuscitation, in trauma. So that is Hartmann's is the best. But if it is not, I mean, it is available in the wards, but if you can't grab a Hartmann's, take normal saline. So the next pint you give Hartmann's like that. So keep on giving fluids until the blood is, so as soon as the blood is available, you give blood. So it will take at least 20 to 30 minutes to cross-match blood. So until the cross-match blood is available, you give O negative blood or group specific blood, and then use blood warming devices. Now, if I mean, in the theaters, I'm not sure whether these things are available in the wards, but of course it's available in the theater. So even the nurses or the in charge, they might not, I mean, they can't remember whether, so just ask them. So they have these things even in peripheral hospitals. We have blood warming devices. So get down them, because the blood is stored in a very minus temperatures. You know that it's so cold when it comes out. So so it will further cause hypothermia. The patient is already hypothermic with the shunting of circulation. So it's very important to warm the blood and give. So it is use blood warming devices if it is available. Yeah, it is available most of the time, right? And then tranexamic acid 1 gram stat. It's an antifibrinolytic agent. So these will save lives. So give tranexamic and then reassess. So you gave your fluids, you gave the blood, you gave tranexamic acid. So, and in this same time, you reassess the patient. Assessment and resuscitation should go hand in hand. So, I mean, so you may need to give further, right? So if the patient is victim of initial resuscitation, if the patient's vital signs are normalized, so that means, okay, about 15 to 30% of blood loss. So you can observe, right? If the patient's parameters are improving, you can observe, and it is improved. And if initially if it's improved and then deteriorate again, then that means the patient may be in a class 2 or 3 sort of hemorrhagic shock. And these patients need more fluid resuscitation and then surgery, and to find out to stop the bleeding, whatever the bleeding source. And then if there's no improvements, especially in class 4 shock, so they will just ooze and they keep on bleeding. The parameters, clinical parameters are not improving. So if you can't find the source, okay, you have to straight away go to a laparotomy or the surgery. So so as a HO, the house officer, there are some practical aspects of blood transfusion. These are very important. So as I said, the blood transfusion, it's in massive hemorrhage, it's a teamwork. So it consists of many members, that is the relevant medical team, either surgical or medical or gynae-obs, and the hematologist, the transfusion physician, the anesthetist, the blood bank and the staff, laboratory staff, and the minor staff. All these are very important. Minor staff is so important, porter. So you have to send so many investigations to the blood bank, to the lab, and you have to get down blood and other products from the blood bank. So these things, I mean, so you have to send someone. So it's a teamwork involving all these people. So, and then of course, so your role as a HO is to initiate and to communicate these things to the certain your seniors. So someone in a senior person will coordinate the rest of the hemorrhage and the blood transfusion. I mean the blood transfusion, the management, right? So and saying that there's no hard, I mean, if you search the massive blood transfusion protocols, guidelines, the algorithm, there are so many flowcharts and these things, but there are specific protocols to your institute. So these protocols will differ from one hospital to another. So when you go to your institute, your hospital, during your first 2-3 days, I think you will be given a chance to, during this orientation program, you will be given a chance to go to the blood bank. So ask them, so what is our protocol in our hospital? What are we do in a massive hemorrhage. And then, yeah, so you would be the communicating person. So communication is very important, right? And then, and the other thing, when you inform the blood bank, so you introduce yourself. So I'm the HO, so and so in this ward, but I'm in the labor room. I'm the obs on call HO, but now I'm in the labor room, or I'm now in the theater, or whatever, wherever the place, you tell where you are now. And then the patient's, the name of the patient, BHT, ward, where is the patient now. So that is also important. And this BHT patient number, the BHT, these are very important to write very clearly, because you know, when you go to the hospital, you will come across these practical things. Even if there is a one a number in the BHT is different, or one letter is different, they will refuse, they won't give, and the blood bank won't issue the blood and the products. So it's important to write this documentation. It's very important, clearly write all these numbers, then the ward, and tell them where is the patient now, because otherwise they will send the patient whatever the blood to the ward. So the patient is there bleeding in the labor room or in the theater. So it is your role to tell them, the communication them, that you are in the patient is now in the theater, so send the blood to the theater, right? And then tell them to activate the massive blood transfusion protocol. So they will do the needful. So you tell them to activate the massive blood transfusion protocol. So every hospital, in every base hospital and above, they have blood banks. So all the blood banks, they have a massive blood transfusion protocol, and there are boxes. Okay, this is the box that we are going to issue in a massive blood transfusion. So, and the other thing is, when the adequate hemostasis is achieved, inform the blood bank to stop. Okay, otherwise they will keep on issuing, right? So stop to issue blood and the products, so that thereby you can avoid waste of blood products and avoid unnecessary, over transfusion. And very important these days, it's the most of the blood banks, they are donors, they can't find donors. People are scared to come to the hospital to donate blood, and their mobile services have been stopped for a while. So they are in a very difficult situation to find blood. So it's very important to avoid waste of the blood and the blood products, and always balance between the hemostasis and the thrombosis when it comes to blood transfusion. And then adequacy should be assessed with your investigation. So therefore the tracing of investigation is also very important, because otherwise you send the blood investigations to the lab and you forgot to trace the investigation. So these things are common, so don't forget. So you trace the investigations, especially the PTI, PTINR, APTT, fibrinogen levels. So these things are very common in further management, right? And then hemorrhage control should be achieved rapidly to prevent the patient going to this lethal triad, and then avoid unnecessary investigations and procedures prior to hemorrhage control. That's also important. And then surgical interventions may need to limit to a minimum. So that's the surgical team will do. So they won't go into further, minor details of the surgery. They will do only the damage control thing, only the major one. So if it is a liver laceration, they will suture the liver laceration. Or if it is a splenic rupture or whatever, they will do the splenectomy and come out. Or sometimes they might need to pack the patient, okay, but they won't go into details, because you have to wait. So for more definitive repairs should be delayed until the patient is hemodynamically stable and physiologically capable of sustaining the further procedures, right? So what are your goals of therapy? So that is those clinical parameters. You check whether the patient is improving with your resuscitation, with your fluid and blood, whether the patient is improving. So a reduction of respiratory rate. So if it is more than 30, if the patient was severely tachypnic, so if it has come down to 20 or less, okay, good, right. Then reduction of tachycardia. If the patient was tachycardic for more than 120, 140, so if it has come down to 100, fine, so he's responding, right? And then increasing of the systole. So you are not going to target for high blood pressures, 130, 140. No, if it is a massive hemorrhage, and if you have given a massive blood transfusion, systolic of 100, 110, fine, that's more than enough. So don't try to achieve high blood pressures, because sometimes, as I said, this reaction hemorrhage can occur, just dislodgement of the clot with that high blood pressure, they start to bleed again. So don't try to achieve high systolic blood pressures. Around 100, fine, that's more than enough, right? So following these sort of patients, and then so with your good fluid resuscitation and the blood, they will have good urine output of more than 0.5 ml. So the renal functions are starting, I mean, it's working. So then so the patient is producing good urine output, and the hemoglobin, if it is more than 8 grams per deciliter, okay, fine, that's enough in a massive hemorrhage and a massive blood transfused patient. Sorry. And then one more slide. So then the other important thing is, once you manage these patients, where to manage them further post-operatively. So usually now, if it was a severe hemorrhage following hemoperitoneum with liver laceration and splenectomy and those kind of patients, most of the time, yes, once you intubate, we will try to keep the patient because he was hemodynamically unstable. So it's not a good idea to extubate on the table. So we usually manage them with the tube on the ventilator in the ICU. But otherwise, say PPH, almost, I mean, most of the PPH we can manage, and then with blood transfusion, they'll be recovered. And then it's good if you can manage these patients in the HDU, or sometimes, I mean, with these days, it's not easy to find an HDU bed. So so you can manage these patients in the ward, in the acute side. You have to monitor them closely, because so for the improvements of the vital parameters, and so to see whether they will start bleeding again, right? Observe for further bleeding, and then don't forget to trace the investigation. And also early mobilization is very important to avoid, especially this DVT and other complication and pulmonary embolism and fatal embolism especially. So it's important to early mobilization, and then look for the complications of massive blood pressure. So once the massive blood transfusion taken place, the patients are hypothermic, they are electrolyte and this metabolic acidosis imbalance, metabolic imbalances, and the hyperkalemia. So the patients may have dilutional coagulopathy and other complications like TRALI, the transfusion-related acute lung injury. So that will further lead to ARDS and even death following massive transfusion. So that's it. And then just to tell you all about this blood and the other products transfusion, as I said, you have to adhere to your own local protocol, hospital protocol, because in some centers, say in NHSL, NHK, these tertiary care centers, they have all these platelet, fibrinogen concentrates, factor concentrates, everything in the blood bank. But in a very, say, a base hospital where I work, okay, example, Dambulla, we don't have in our blood bank, we don't have platelets in the blood bank. So we have to get down from a nearest other hospital like Matale or Polonnaruwa, or wherever. So until such time you can give blood and FFP is usually available. So if you are in a tertiary care center, okay, 1:1:1 ratio, that is blood, the platelet and the FFP. So those are some centers, they adhere to that sort of protocol. Whereas in some centers, after 2 units of blood, you give 1 unit of FFP, and after further giving of 1 blood, you give another platelet, FFP, cryo, and so on. So, so as I said, you adhere to your local protocol and give blood and the blood products. And also important to identify when to stop giving blood and to when to stop and to when to tell the blood bank to stop sending blood. So that's all my lecture. So in the chat box, we'll see what are the is there any indication of giving warm blood? So as I said, so you know, this hypothermia blood is in a minor temperature, so it's very cold. So it's good if you can give through a blood warming devices. Now sometimes we do have, you try to, you know, with warm saline, and you put a you make a loop in the saline drip set and give it through. So those are not very, I mean, very accurate or very good way of giving, but there are some specific blood warming devices. So it is in a massive blood transfusion, it's very important to give warm blood to avoid patient go into further hypothermia. Yes. How do we decide whether the patient required massive transit protocol or not? Is there any criteria? So that's what I mean. You go by your clinical parameters, and if the patient, and if you are class 1, 2, 3, 4, so say whether in which category, in which class the patient is on. If you can't, I mean, if the patient's blood pressure is unrecordable, is tachycardic, so you have to always, if the patient is in hypovolemic shock, unless proven otherwise, so there is the indication to start your massive blood transfusion protocol. So give a call to the blood bank, activate the massive blood transfusion protocol. So they will activate, and they will send you the blood and the products. Right. So I can't see any more questions. How to set the rate of an infusion within how much of time should give a pack? Yes, so that is important. Sometimes you have to, in a very dying patient, you give as soon as possible. Sometimes you squeeze. There are some pressure bags where you keep increase the pressure and squeeze the blood. And there are some ways where you put a 3-way cannula and pump the blood. You take the blood from one end from the blood pack, and then give from the other end. So there are 3-way taps where you can pump the blood. So the rate, of course, I mean, if the patient is bleeding massively and the only thing is to give the blood, then you just pump, squeeze, and pump as quickly as possible. What are the other questions? Any more questions? Hello, are there any more questions? Can you all hear me? Are you all there?
Yes, can hear, yes. Few questions on the chat box.
Okay. Yeah, madam, do we need to consider about MAP? Yeah, yes, okay. Yeah, the MAP, of course, if you can't, I mean, if the blood pressure, automated regulated blood pressure readings come, then of course with your systolic and the diastolic pressure, there will be a MAP will be appearing. But if you, I mean, in the ward setup, if you manually reading, so you won't be able to calculate map and see in this difficult scenario. So say for as I said, the systolic blood pressure around 100, so then your map would be like 80, 90. That's more than enough in a massively massive hemorrhagic shock patient, massive transfusion. So your map around 80, I would say. Yes. Maybe more.
I think that's all the questions from they put on chat box. If that is all the questions we have.
Yeah, in a practical way, yeah. If there is no blood warming device, what are the options? So that's what I mean. In the theater and in the wards, we have, you know, this warm saline. So there are warm salines. So you can cut the warm saline on the top, and then you make a loop of your infusion set and put it inside the warm bath and give. So at least you give sort of a some sort of warming. So that would not be the ideal, but in a desperate situation where you can't find in those sophisticated devices, yes, this would be the other option. Yeah.
Right.
Okay, then thank you
Yes.
for listening, and yes, and good luck, and wish you all the best with your internship, and enjoy your internship, and also don't forget these days COVID, so make adequate precautions and measures when you come in contact with the patients. Okay, thank you.
Right. Thank you, ma'am. So that wraps up today's program. So make sure that you all log in tomorrow by 9. So those who cannot log in, we will do live streaming on the College of Anesthesia YouTube channel. So the link we will share in the morning. Right. So thanks. Thank you, everybody. Thank you.